Good afternoon to all, respected dignitaries. I'm Dr. Keerthana A. I'm presenting a rare case of Metachronous mucinous adenocarcinoma of upper lid and OSSN. Multiple primary malignancies was first described in 1879 by Bill Roth. The North American Association of Central Cancer Registries classifies multiple primary malignancies into two categories. First one is synchronous, in which the cancers occurs at the same time, and metachronous, in which the cancers follow in sequence, that is more than 6 months apart. Here we describe a rare case of a 37-year-old male with metachronous mucinous adenocarcinoma upper lid with ocular surface squamous neoplasia. He presented with complaints of mass in right eye upper lid since 6 months, gradually progressive in nature, not associated with pain, discharge or bleeding. He also had a raised fleshy growth in right eye white part near the limbus since 4 years, not progressing in size. There was no history of any ocular trauma or previous ocular surgeries, and patient had no known comorbidities. On examination, ocular symmetry was lost due to mechanical tosses and mass on right eye upper lid. The mass was of size 2 into 0.5 centimeter, involving the lid margin and extending 0.5 centimeter above it and horizontally extending from center of upper lid to lateral canthus with irregular borders and overhanging edges, firm in consistency. On slit lamp examination, right eye had a raised fleshy lesion, 0.5 into 0.5 centimeter size near the nasal limbus, encroaching the cornea and with engorged feeder vessels. The clinical appearance of the lesion was not correlating with basal cell or squamous cell carcinoma, so incisional biopsy from right eye upper lid mass was done and sample was sent for histopathological examination. The HP report of the mass showed subepithelium with pools of mucin, hyalinized stroma, and tumor cells arranged as tubules, glandular structures with oncocytic cytoplasm and pleomorphic nucleus, suggestive of mucinous adenocarcinoma, primary or metastatic. Right eye OSSN was excised and amniotic membrane graft was placed. Here we can see the fibrous septae, tumor cells arranged as glandular structures and pools of mucin. Patient was further investigated for gastrointestinal and seminal tumors and primary malignancy was ruled out. Patient underwent wide local excision biopsy of right eye upper lid anterior lamellae. Posterior lamellae was left untouched. Sample sent to HP for clearance of posterior margin. Tarsal plate of right eye upper lid left intact. Free skin grafts were placed and right eye upper lid reconstruction was done. Here we can see the wide local excision with free skin grafts. Primary mucinous adenocarcinoma of eyelid is a rare malignancy with an incidence of 0.07 per million. First described by Lennox et al. In 1952, its incidence is more common in Caucasian males with median age of presentation being 6 and 7 decades. An exceptionally rare neoplasm with a propensity for local recurrence and metastasis and slow rate of growth which leads to delays in being brought to medical attention. Accurate diagnosis of PMA requires a high index of clinical suspicion and accurate histopathological diagnosis. It should be suspected particularly in patients with recurrent eyelid lesions and must be differentiated from metastatic disease. A word about OSSN. Ocular surface squamous neoplasia is used to describe neoplastic epithelial abnormalities of conjunctiva and cornea. It ranges from squamous dysplasia to invasive squamous cell carcinoma. It is mostly unilateral and is seen in middle-aged and older patients. Usually presents as a fleshy, gelatinous elevated lesion. Complete surgical excision with 4 mm margin clearance, no-touch technique is the treatment of choice. So upper lid is a rare site of mucinous adenocarcinoma for which successful surgical intervention was done, achieving adequate margin clearance, very good cosmetic outcome and patient satisfaction. Surgical removal with continued regular follow-up examination is the treatment of choice. Here is the patient, immediate post-op and 3 months post-op. These are my references. Thank you.
You did any mucin staining was done like Alcian blue or colloidal iron?
Staining was not done.
Mucinous staining. The mucoepidermal carcinoma is one of the carcinoma has been described in the lid, conjunctiva, even the lacrimal sac, where you will get that mucoepidermal carcinoma. But I have not seen that adenocarcinoma of the muco thing. Any comment?
Yeah, this is a very nice presentation. Only one thing in mucoepidermal carcinoma, especially when it occurs in the periorbital and the lid region, it is highly metastatic. Like the MSI, the microsatellite invasion is very high. So have you done any examination of the lymph node or any PET scan, anything like this to know the MSI?
Lymph node examination was done, ma'am. USG was done. There was no other lesions. X-ray was done. But PET scan was not done, sir.
This is essential to know the microsatellite invasion.
Yes, yes, ma'am.
Yeah, excellent, Keerthana. Very nice case. And as ma'am said, it's good to systemically evaluate. So you call it primary, right? So you have to
Yes.
always rule out secondary.
Rule out
I know
all,
most of our patients cannot afford a PET scan. That is probably why, because in a government setup,
Yes.
we usually do an ultrasound B scan, a chest X-ray, or a chest CT scan. But I think PET scan is becoming a little bit more affordable currently.
Yes,
In
ma'am.
government setup, you know, they get it done even for 10,000, less than 10,000 K. In private setup, it's around 18K. So it's a little bit of effort. Just go explore the possibility of it.
Yes.
This is for all the audience, so it's always good. Good that you presented this case. We are always aware of, you know, sebaceous gland carcinoma, basal cell carcinoma, squamous cell carcinoma. So even a sweat gland tumor can arise, and most of these time, it appears as like a cystic translucent area. You know, it could be an apocrine cyst or an eccrine cystic lesion. So we often leave it there, you know, until and unless it doesn't have a stark appearance of a squamous or sebaceous or basal cell. Sometimes we give an option to the patient. It's okay, it's cystic, you can observe what you want, but all these lesions should be excised, you know, and especially something which is growing progressively. So there is an entity called sweat gland carcinoma, sweat gland tumors, which should be aware of, although it looks very benign and cystic. Thank you.